and the topic today is communication skills in oncology. And I'll be honest that I had never given a talk on communication skills before. I write a lot about it, I talk a lot about it, but I had never given a formal talk about communication skills. I usually talk about evidence appraisal and critical appraisal skills, but this was a very nice opportunity to think me formally about it as well. So my first disclosure is that I'm not an expert in communication skills, but I'll try to share my experience as a medical oncologist and as someone who thinks about this and writes about this in terms of what it actually means and how important it is for an oncologist and all healthcare professionals to better train ourselves in communication skills. And I understand that there are a number of talks specific to the training of communication skills that you will hear later today. So I'll try to give more of a background about why communication skills matter in oncology. So first of all, I think one of the privileges as well as the challenges of being an oncologist or being a healthcare professional in general, especially when we're dealing with breaking bad news and other delicate communication points, is that, for us as a healthcare professional, it could be that patient could be one of the 100 patients for us, one of the dozens of patients that we see in that day, one of the hundreds of the patients with similar conditions, similar scenario we see in our career. But for that particular person, for that particular patient, it's the doctor, the day, the moment. That person, that clinical encounter between us and the patient will be embedded in the memories of that patient for their whole lifetime, and the memories of that family. Every casual word we utter in that clinic will be remembered forever. And nowadays sometimes it will be recorded forever too. So there is no doubt that we need to take communications skills as much important part of our training as we do for any other skills. And in fact, especially for the field of oncology and maybe palliative care, I think this is the most important skill that a doctor must have. And one other point that we keep forgetting is that listening is an important part of communication. Communication skills does not always mean what we talk about or what we say to the patient. It also means how we can gather more information from the patients and how we can listen to them well, and listening in itself can be a part of the healing. And sometimes the patients do not necessarily want any intervention. Just the validation of the feelings and reassurance might what they be seeking from us. And one other point that I'll highlight in my talk today is when we talk about communication skills, we usually think about breaking bad news, but that is an important key of communication. But communicating good news also requires skills in oncology. Good news also come time and again. The scans are good, the results are looking promising, but how to balance over exaggerating the promise and to keep the patient realistic is also an important technique. And communication skills, if we can improve upon it, it has been empirically shown that it will improve the quality of care, patient satisfaction, as well as our own professional well-being. So this is just a background about why communication skills are important in oncology. But I guess other important question that we should be asking is, can communication skills be actually taught and trained? And I have a couple of thoughts about it. First, I think a bad human being is never going to be a good doctor. If you are not a good human being to begin with, you are never going to be a good doctor. And I guess that's the reason why we have a lot of these aptitude tests to screen and filter out students who may not fit to become a good doctor. It's not about knowledge, but it's about the aptitude. But can you train someone to be a good human being then? I think that's pretty difficult. If a person is a bad person, then it's very difficult to train that person into a good person. However, good persons are not necessarily good communicators. There are many good human beings and good doctors who are not necessarily good in communications. So it is for for the sake of these trainees, that it is important to provide training in communication skills. Good human beings can be trained to be good communicators. And that's why we have all this communication skills training. We start with the assumption that all the doctors or all the participants in this profession have been filtered out through the screening process. They are good human beings, but they don't have good communication skills necessarily. And that's where the role of communication skills come into play. And this has been empirically proven through a number of studies that if you provide training skills, then it does lead to improvement in communication skills, and that in turn translates into improvement in patient satisfaction as well. But as I was referring to this earlier, communication skills does not necessarily mean breaking bad news alone. Although that might be one of our focus in oncology, it does not mean breaking bad news alone. There are several key communication points in the cancer care journey of a patient. The first is definitely the first visit that we refer to, which is the first time the patient receives the diagnosis and visits an oncologist to discuss about what that diagnosis entails and what the prognosis would look like. And this may or may not be bad news. Sometimes it's a benign cancer. The chances of cure are pretty high, and we could be looking at the positive side of the side of things. Things could always be worse, but sometimes it is an advanced cancer, metastatic disease, probably not many treatment options like glioblastoma, which would be the worst news the patient can ever have in the lifetime. So that is an important time point. The other one is, which comes routinely in practice, is scan results. The patient will have scans to assess treatment response, and the patient will be waiting to hear about the results of the scan. And they would literally be counting hours until they hear from us about what the scan shows. And it can be good news. The tumor is responding. Everything looks good. The tumor hasn't come back. There is no relapse. Such good news. And sometimes it can be bad news. The treatment is not working anymore. The tumor is growing. We need another intervention, or maybe there is no more intervention. The other is blood work that we do at every week or during every chemotherapy cycle. The blood work looks good. You are fit for chemo. The blood work does not look very good. You are not fit for chemo. These are not as big news as the other two, but still that can affect patient care and patient satisfaction. The other is about making chemo decisions based on the symptoms and the blood work and all those things about whether we should be delaying the chemo, whether we should be skipping the chemo, dose reduction, or the possibility of going through the planned protocol of chemotherapy. These are all quite important communication points, and one can do quite badly if one does not communicate these things well, although one is a very competent doctor. But I think one of the most important points during this cancer journey is about assessing risk and benefit of a new treatment. Whenever the patient is with us and we are talking about whether or not to use a new cancer drug or offer a new cancer intervention. So I think the most important point is when we are discussing about the risk and benefit, and we are trying to make an assessment of whether or not this new cancer drug or a new cancer intervention is fit for that particular patient in that particular scenario. And it needs quite a bit of understanding of risk and proper communication of risks and benefits and a shared decision making of the patient. For example, most of us might have heard or read this seminal essay by Dr. Gould about that says the median is not the message. In his personal case, he was diagnosed with mesothelioma and was quoted the median survival time, which went into his head, and he was literally thinking that he would die at that time point, but he beat all the odds. And this was his message to the public, that the median is not necessarily the message. Median is the time point beyond which 50% of the patients will survive by definition. So that was his message. So what does that mean? When we're talking with the patient, let's say we have a patient with metastatic colon cancer in front of us, and the patient is asking us, "Doctor, how much time do I have?" So this is quite tricky. The median is not the message, but neither is the mean, nor is the hazard ratio. How do you properly communicate the risk or the odds of survival or the benefits of treatment to the patient. Uh, One thing that we know is that we don't know very well. We don't have the means to make these predictions very well. We're getting better and better, but we are not accurate. And this communication of uncertainty is difficult, but is the key expertise that we would expect from a healthcare professional. There have been plenty of studies, in fact, about how good we are about estimating or prognosticating patients with cancer. And all the studies, I'll show you three different studies from three different time points done in 2003, 2007, 2000, and one quite recently. But all the studies, they show consistently that clinicians, healthcare physicians, we consistently overestimate survival. So we are always optimistic. The other study, the first study for all terminally ill cancer patients, the second study is for lung cancer patients. Again, it shows that the clinicians overestimate survival. The third is for head and neck cancer patients from 2020, very recent. It also shows that physicians tend to overestimate survival. So I guess we have that bias as a physician that we believe our interventions will work and will lead patients to have a longer life. But studies have shown that we consistently overestimate survival. And why are we so the question is, why are we so bad at making these predictions? Because the problem is that we rely on clinical trial evidence, which is not necessarily reflective of what will happen to that particular patient. I call this the cascade of surrogacy, because what we need is the survival, overall survival for my patient in front of me. How I'll make that guess is based on what is the overall survival in the real world of similar patients, many of those patients out in the world, and that data I usually don't have. So that comes from inference from overall survival I see in phase 3 clinical trials of similarly enrolled patients. And sometimes, and many times, this data is not available, and we have to rely on progression-free survival in the phase 3 clinical trials. And some of the drugs are approved even without this data, so we have to rely on response rate in phase 3 trials sometimes. And nowadays, most of the drugs are approved even without phase 3 trial on the basis of phase 2 alone. So we have to rely on that. And sometimes you see that there is no clinical trial data, and whatever we are doing are based on just observational studies. So this whole surrogacy cascade makes it quite difficult for us to understand what might happen to the particular patient in front of us in the clinic. But I think that's the most accurate statement, and but the one that's most difficult for us to say as a healthcare professional is, I don't know. But this should be the most accurate statement that we could ever say. We don't know a lot of things. There are a lot of uncertainties in the practice of oncology. However, what we know is there are range of possibilities. We can go to the range of the possibilities, the best case scenario and the worst case scenario. And what we also know is that for a number of the interventions that we do, there are some with hard level evidence, solid evidence from a properly conducted phase 3 randomized trial against an appropriate control double-blinded trial. And there are low levels of evidence. Some interventions are based on observational data on the basis of phase 1, phase 2 trials. And what we also know is that some interventions have substantial magnitude of benefit, and some interventions have quite marginal magnitude of benefit. And there also comes the discussion of paternalism versus autonomy in intervention that has hard level evidence with substantial magnitude of benefit. Maybe we can be a little more paternalistic about it, and we can in stronger terms. And if that's not the case, if there is an intervention with low level of evidence and quite marginal magnitude of possible benefit, strength of recommendation would be quite low when talking to the patient. So some common sense, general communication tips when discussing these ranges of risks and benefits would be, let's talk about relative risk reduction. Sometimes we keep citing interventions reduces the risks of the disease or any bad outcomes by 90%. That sounds fantastic, but we should also be keeping in mind what the baseline risk is. If the baseline risk is quite small to begin with, even a 90% risk reduction might not be that useful for the patient. And we should always consider the denominator and the absolute numbers. Someone might say, oh, the risk of serious adverse event is only 0.5%. But if it's an intervention that will be used in millions and millions of patients, like the COVID vaccines, then even that 0.5% can turn out to be quite a big deal. So, there are always chances of being misled by these percentages and risks. So we should keep these factors in mind when we are sharing the risk and benefit assessment with the patient. Just a thought exercise, let's say we have a patient who came back as having an elevated prostate-specific antigen PSA levels on a routine screening test. And the question now the patient has with us is, should I undergo a prostate biopsy to make sure that this is cancer or not? It's not an easy yes or no decision. And that's why communication skills is so vital. In this particular case, we need to consider what are the possible range of chances that an elevated PSA for that person at that age, given that person's family history and everything else, may be a cancer. And what are the ranges of chances that it will actually kill the person if it were a cancer? And what are the chances that the treatment may help in reducing that risk? And what are the chances of getting serious side effects from the treatment? So all these ranges of estimates should be considered before taking an informed decision. And obviously, there is not going to be a single correct answer. And one of the most important communication points in oncology is breaking bad news, of course. We do this day in, day out. And as an oncologist, if we are not comfortable with breaking bad news, then that's being a pilot and not being comfortable with an airplane. This is the bread and butter for an oncologist. Robert Buckman has put it very elegantly about the talks of breaking bad news and why it is so sensitive for us. If we do it badly, the patients or family members may never forgive us. If we do it well, they will never forget us. And I'm not here to talk about how to break bad news. I think you have that session coming up subsequently about how to break bad news, and you have a number of guidelines about it. ASCO has a guideline. There is the spikes protocol. And nowadays, in the era of telemedicine due to COVID, they even have something called the wire spikes. This is something many of us may not have been aware about. Wire spikes is just a modification to spikes. Adding the technology factors and the online factors to the spikes protocol in discussing bad news. But I want to talk about something that is beyond that, something that the guidelines and the protocol do not necessarily train you. This is a commentary that I had written for Medscape. I practiced in Nepal, I practiced in Japan, and now in Canada. And I have given bad news to patients in all of these countries. And I wanted to share my experience of how culture and cultural context makes things different. And breaking bad news is not necessarily the same in different cultural contexts. You never get a formal training on how to react when the patient in front of you starts to cry. The patient is in the clinic with you and the patient starts crying. What should you do? Should you go and cheer the patient up? Should you give some false hopes? Or don't worry, maybe there are other treatments available. And I have seen other patients live 2-3 years with similar condition. Or should you just go and give a hug to the patient? What is an appropriate response? And of course, there is no correct answer. It depends on the cultural context. And this is, I think a lot of us can equate with that feeling of being in that awkward position, not knowing what to do when the patient in front of us starts to cry. And we are definitely not, but it comes with practice, with experience, and most importantly, learning from, seeing people you respect, your mentors and other people, how they react in that situation. And there is no one size fit all answer here. And you need to definitely keep the cultural context in mind. Hugging a patient might be an appropriate response in some context. If you're practicing in North America, in Japan, that would be a taboo. In countries like India and Nepal, we don't usually hug our patients, but we sometimes do put some strong paternalistic words of encouragement and support. So we need to consider all these issues, the patient issues, the family issues, and our own oncologist point of view, and try to make that balance between autonomy, the patient's autonomy versus medical paternalism on our end. This is a delicate balance. And, in case of North American culture, European culture, there is a strong focus on patients' patients' decision making and full disclosure to facilitate that informed decision making. But in our part of the world, in India and Nepal, the family plays such an important role. And like this must have been all of our experience, that the family comes to us and says, please don't tell my dad or like whoever the patient is that she or he has cancer. They will be devastated and they won't be able to survive. So they will stop the doctor from breaking bad news to the patient. So that is where we need to make that decision between patient autonomy versus the patient's right to know information. And it's not an easy discussion. In this other paper I had written for Medscape, I talk about discussing patients' private lives for better cancer care. Sometimes we believe that death is the most important outcome, which usually is, but for some patients, there are things in life that are worse than death. But if we don't ask about it, we won't know about it. This particular paper was about a patient with cancer who was more worried that she had received cancer from her partner. She was worried that it was a sexually transmitted disease. Then she was worried about the outcomes of cancer itself. And we were all treating her cancer. She had metastatic rectal cancer. We were all treating her cancer, talking about treatment protocols, about chemotherapy schedules, side effects from chemo. And she was having a good treatment response. And we were discussing, oh, you're having quite a good response. We are very happy with what we are seeing in this cancer. But the patient never seemed happy. Like even when we were giving good news, the patient never seemed happy. So I wanted to dig deeper. What's the reason for this? And when we started talking more and more about it, and it needs a certain level of doctor-patient relationship and comfort on the patient's end. Finally, we found out that the reason for her worry was something else. She was not even worried about cancer. She was worried that it was a sexually transmitted disease. The other challenging scenario that I have faced recently, and I have written about it, is nowadays due to COVID, most of our clinics have become virtual and we talk over telephone. So how do you break bad news over telephone or through Zoom calls? And especially this was a scenario where I was covering for a different colleague of mine. And so I had never met this patient before. I was covering for a different colleague. So how do you break such serious news to a patient whom you had never met before over telephone? And the other point that I would like to bring forward for discussion today is about the quality of life-death transition. For some reason, we try to avoid the word death all the time in oncology. But I think this is something that we can't escape away from. So instead of trying to run away from death, we need to focus on how to improve the quality of life-death transition. There have been a number of very important studies about this. This was a paper in JAMA Oncology in 2016, 2017, where they looked at the quality of, here you can see the word QOD. QOD means quality of life near death. So they measured quality of life near death, and they found that even among patients who have good performance status, patients who were doing physically fit, they saw that the use of chemotherapy in the last 6 months of life was associated with worse quality of life near death. So the question is, why do we keep treating our patients with these difficult interventions until the very end of life? This was about last 6 months of life. We similarly have studies that show that patients are getting chemotherapy in their last week of life. So, okay, last 6 months of life, maybe we are bad at predicting and we could not make a guess. But what about the last week of life? I think we are more confident about making prognosis about, okay, this is possibly the last month of life, last week of life. But patients are getting invasive cancer interventions until the very end of their life. So why is that happening? And I think we need to talk more about it. There was a very interesting editorial published alongside that previous study that I talked about. And in this editorial, the editorialists say, they tell that cost aside, we feel the last 6 months of life are not best spent in an oncology treatment unit. or at home, suffering the toxic effects of largely ineffectual therapies for the majority of patients. I couldn't agree more. But it has somewhat become a taboo that we don't talk about death, and it's always quite easy to just talk about the next intervention and the next intervention and the next intervention, which may not always be in the best interest of the patients. But if we can't communicate that well, the patients will never know about it. So it is the onus on us to communicate it effectively. We had published this paper in 2018 in the ecancer journal about these issues. Why are patients getting treatment in the last 6 months of life? And is this a scenario where probably we should be focusing more on non-drug interventions? So we try to look at the literature about why do we do this? Why do we continue prescribing drugs in the last 6 months of life? And we found that there were a couple of reasons. One, as I mentioned, we physicians are unusually optimistic about survival, and we think that the patients are going to live longer than they actually do. But it's not only that. There are also some, and there is ease of treating. There is a bias against treating. We believe that our interventions work. And second, as I mentioned, it's much easy to avoid that discussion about end of life than to just say, okay, let's try this other chemo. Maybe it will work. And the other thing is about, I don't see that as often in countries like India and Nepal, but it's quite common in the West, is that patients with cancer, they think that cancer is a disease to fight against, and they think of themselves as a fighter. And they say that this is a war on cancer and I have to win this war. I'm not going to, lose this battle, so I'll keep on fighting. And that is quite harmful. So, I think it is quite important for us to think about this peaceful life to death transition as a metric, as a healthcare quality metric in itself, and not focus on survival metrics alone. This is an obituary I read. This is not my patient, an obituary of a different patient that I read, and and it really touched me. The whole obituary is quite interesting and makes us realize what makes life so beautiful and what is important in life. So I have put a link here in case someone wants to read the full obituary, but I have just copied one paragraph here, and I want to read this with all of us. It says, Tim led a good life and had a peaceful death, but the transition was nasty. And for the record, he did not lose his battle with cancer. When he died, the cancer died. So technically it was a tie. He was ready to meet his maker. We are just not sure that the maker is ready to meet him. So I think all the patients do deserve a quality of a peaceful life-death transition. That is the least we can do for our patients. But the problem is, the whole dying thing has become so medicalized. This is a picture of dying from 1891. And I think the patient is having, as long as we can provide pain relief and other symptomatic measure, I think the patient is having otherwise a quality of life-death transition. But in 2021, this is the scenario. We are not allowing anyone to die peacefully. Even when the patients have explicitly expressed that they want to die in home, for some reason, that's not happening. So we need to talk more about dying. We need to think more about dying. And we need to allow dying, a quality of life-death transition, to be a metric in itself. And what about medical education? Why is this happening? Because medical education is failing us. We don't talk about dying. We care for the dying. There have been a number of interesting studies, surveys of residents who say that they felt that their residency education was inadequate to address this topic, and 25% felt uncomfortable discussing these issues with the patients. And these are studies from the West. I don't know what data are for, and I have not seen much studies about residents' comfort with talking these end-of-life care discussions in South Asia. But I think that would be one area that we could work on, and I think it would be an interesting area to study. And even now, even in the West, after all of that emphasis, doctor-patient communication is perceived to be the area where the families of dying patients provide the most negative comments. It is challenging because it's not empiric. There are no hardcore evidence about how caring for the dying, how should we be caring for the dying, there is some spiritual nuance associated with that, and the teachable moments. If we were to have some trainees shadow us during caring for the dying, there are actually very few teachable moments in terms of the interventions that we could teach. It's more about the generalized approach, and the teaching moments are quite subtle there. But the skills will improve with training, and mostly, I think this is the key point. I think there are not like points to teach the trainees about how to care for the dying per se, as it is from seeing the overall approach the attending or the faculty has, and watching those mentors at work, and just imbibing the philosophy and the process. Any talk on communication skills is incomplete without a word on palliative care. I think the traditional branding of palliative care has been a problem, and because when we talk about palliative care, we think about just the dying patients alone. And as a result, a lot of the physicians and patients, they decline to receive palliative care from the beginning of their cancer journey, when in fact we have multiple studies showing that it is helpful not only to improve quality of life, but also longevity for the patients. So this palliative care is in a serious need for rebranding. And I think instead of just dying or hospice care, if we could rebrand palliative care as something that will promote courage, tranquility, intimacy, dignity against low value drugs that just contribute to financial toxicity for the patients, but do not necessarily improve outcomes. And this is quite challenging because everything seems to be going against that. There are financial incentives for overdoing things. Everybody benefits from overdoing things. The hospital, the doctor, the whole healthcare ecosystem, except for the patients, which should matter the most. So we have that responsibility to advocate for our patient. It's not easy, but that is also one other area where communication skills will come into play. As I said, this is the first time I've ever talked about communication skills in a symposium. I have learned a lot from Professor Nathan Cherney, Professor Scott Berry, and Dr. Remy Shedam. Professor Nathan Cherney is the president of the ESMO MCBS team. Professor Scott Berry is a medical ethicist and our department head here at Queen's University in oncology, and Remy Shedam is a palliative care fellow at Sloan Kettering. And I have received some of these tips and slides from all of them. So I'd like to express my gratitude towards them. Thank you.